Good morning, good afternoon, or good evening, everyone. It's midday now, the time scheduled for the start of the webinar. I will wait another 3 minutes and then we will begin. But welcome to all of you. It would be terrific if you could put in the chat your name and your role and where you are from to introduce yourselves to the team here. Thank you. Okay, I think we will start now. Once again, good morning, good afternoon, and good evening, everyone, and welcome to World Immunisation Week 2024. Humanly possible, saving lives through immunisation. And so to kick off, we're going to hold this webinar on vaccination of healthcare workers for seasonal influenza and other diseases. And my name is Dr. Belinda Herring, and I am the influenza focal point in emergency preparedness at the WHO Regional Office for Africa. And I'd like to introduce you to my colleagues who'll be joining me on this webinar, Dr. Rina Doshi, and also, if you introduce yourself, Rina.
Good morning, good afternoon, everyone. My name is Rina Doshi, and I am the focal point for immunization in emergencies at the Regional Office for Africa.
Thanks, Rina. And Rina is actually sitting in DRC, and so her internet is not quite as good as it is here in Brazzaville. And so when she presents her slides, she may turn her video off to save bandwidth. And the other important guest that we have today is Dr. Joe Breezy. He is the Director of the Respiratory Virus Prevention and Preparedness Team at the Task Force for Global Health. So Joe, if you could introduce yourself, that would be terrific.
Yeah, hi everybody. Joe Brzee from the Task Force for Global Health, which is an NGO based in Atlanta that supports health worker vaccination and other vaccination programs for the life course. Nice to see everybody.
Thanks very much, Joe. And so we have to kick off today with some housekeeping. So to begin the housekeeping, I'll find the slide. No. So please note that this virtual training adheres to the Code of Conduct to prevent sexual harassment and harassment at WHO events. Oops, wrong way. We have a question feature and also the chat. So I have asked you if you can introduce yourself in the chat. Please put your questions in the Q&A so that we can monitor just one place for questions and answers. We do so those two features are available. The other feature that is available is we have interpretation in French and Portuguese and English. So to access this, on the bottom of your screen, you go to the little globe, and then if you click on the globe, it will come up with the type of interpretation that you would like, which may be English, French, or Portuguese. And you'll be able to access the webinar in your own language. We also have live transcriptions or closed captioning. So you can click on show captions or hide captions. And this feature is, once again, I think it's either at the top or the bottom of your screen, and it's next to the record button. So what this will do will be the text, there's written text underneath as the computer interprets it. Okay. This webinar will also be recorded, and the materials should be available. So they'll be available after the webinar. And I think that is the end of the housekeeping. So I don't think there'll be any questions following that. Just let me share my screen to start the program for today. Okay, is that good in presentation mode, Mohammed?
Yes, it is.
Excellent. Okay, so we will kick off our presentation today. So the title is about protecting the health workforce and vaccination of healthcare workers for seasonal influenza and other diseases. And as I mentioned, this is a part of World Immunization Week 2024. No. Right, got the right button. So why would we want to vaccinate healthcare workers? In thinking about a healthcare worker population, that of course includes our doctors and our nurses, but it also may include other people who work in the healthcare industry, say the cleaners in the hospital, potentially dentists, if we're thinking of a pandemic situation and life has to go on. So there's a whole range of people that fall under the healthcare worker title. So vaccinating healthcare workers will protect that vital workforce in the case of a pandemic, and it is cost effective. It's been shown to reduce the delivery time for influenza and other vaccines in the event of a pandemic. Vaccinated healthcare workers can act as advocates for vaccine delivery and vaccine uptake, and they can improve the community uptake for vaccines. It's also been shown that there is improved acceptability of adult vaccination in a post-COVID-19 landscape, and this is introducing the life course approach for vaccinations. And considering that healthcare workers are part of that adult group, that is why we should, think about vaccinating healthcare workers. And finally, vaccinating healthcare workers is a critical part of pandemic preparedness. And if we bring back the memories of COVID-19, we know that the healthcare workers were a sector of the population that were adversely impacted by COVID. So moving on, I'm going to hand over to my colleague Rena to go through some of the slides that we have, which present some of the data relating to healthcare worker vaccination. So over to you, Rena.
Thanks so much, Belinda. So we do know that healthcare workers are at an increased risk of vaccine-preventable diseases, given their close physical contact with patients and with bodily fluids. In West Africa, it was actually estimated that healthcare workers were 21 to 32 times more likely to be infected with the Ebola virus disease than people in the general population. And so if you just look at the graph on the right, you can see here the number of confirmed and probable healthcare worker EVD cases over time and the proportion per outbreak of healthcare workers. So you can see that healthcare workers represent a substantial proportion of the cases. Next slide. So healthcare workers are also the backbone of the healthcare system, but they're often the first to get sick. So looking at the graph on the left, you can see here that at the very beginning of an outbreak, before the date of declaration, we're seeing healthcare worker infections. And this is just looking at the Ebola virus disease example again. So without knowing that Ebola is being transmitted, these healthcare workers can perpetuate nosocomial disease transmission to vulnerable patients at higher risk, and also at the start of these outbreaks. And this can also lead to shortages of healthcare workers, which put stress on our systems. So now moving to the example of influenza. Influenza vaccination is cost saving or cost effective. Looking at this analysis that was done in upper middle income countries and lower middle income countries, you can see that healthcare workers, the box in the red, vaccination of healthcare workers is both cost saving and cost effective. Next slide. So, we've seen now over the last 15 years, 2 different pandemics, and the H1N1 pandemic really highlighted the gaps in pandemic preparedness and vaccine delivery. So back in 2009. So low resource countries received vaccines 3 months later than high income countries. Countries with influenza vaccination programs were able to distribute more vaccines than those without those programs. And also these countries without influenza vaccination programs lacked established regulatory pathways, legal agreements, national vaccination policies, and distribution systems, which really slowed vaccine distribution. And if you look at the graph on the right, you can see the comparison in vaccine doses administered with the blue bar with seasonal influenza programs and the orange bar with no influenza program. So seeing how those with seasonal influenza programs received more doses. Next slide. So countries with healthcare vaccination, influenza vaccination programs also reached higher COVID-19 vaccination coverage among priority populations. So if you're just looking specifically at the priority population of healthcare workers, you can see that looking at the box highlighted in red, countries with influenza vaccination programs for healthcare workers had reached higher coverage, 83% compared to 22%. And then looking at the below box, lower middle income countries with no influenza reached much lower coverage. So the blue is comparing just single dose coverage of COVID vaccine to the unvaccinated. Next slide. So existing programs are associated with higher vaccination coverage in the general population as well, not just our priority population. So again, looking at the graph on the right, we can see the black line represents countries with influenza programs and average coverage, and then the blue line represents countries with no influenza programs and the average coverage. So low and middle income countries with influenza programs prior to the COVID-19 pandemic reached higher COVID-19 vaccine coverage quicker than countries with influenza programs. So you can see that line really increase much faster. And then 12 months after introducing these vaccines, countries with seasonal influenza vaccination coverage reached an average of 47% coverage of the total population with the primary series, compared to 22% in countries without influenza programs. So a pretty big difference. And this trend was actually also observed in Gavi eligible countries as well without influenza programs. Next slide. So you've probably seen this slide as we've talked about this a lot with COVID-19 vaccination, but influenza vaccination is also a public health opportunity as we shift our way of thinking towards this life course approach and all age groups needing to be included in the immunization system. So this is a great example of Lewin's model for change management, where we unfreeze our way of thinking that vaccines are just for children, and start reframing it differently. From childhood vaccination, which is the change to vaccines for all ages, and then refreeze in this life course immunization approach as part of public health, as part of PHC and pandemic preparedness. So refreezing that way of thinking that vaccination is really for all age groups in all populations. So reaching priority populations, so COVID-19 vaccine and seasonal influenza as part of this life course immunization approach. So for both groups, they overlap quite a bit. Our key priority population is those healthcare worker professionals. And by reaching those, you can also begin to reach those other groups. So individuals with chronic medical conditions, elderly individuals, pregnant women at any stage of pregnancy, and of course our children as well, because those healthcare workers are really advocating and acting as ambassadors for encouraging the community to get vaccinated. Next slide. And now I'll turn it back over to Belinda to talk a little bit more about the specifics. Over to you, Belinda.
I'm muted and I'm talking to myself. Thanks very much, Rena. So if we look at pandemic preparedness, and we've just, as Rena mentioned, we've just been through the COVID-19 pandemic and we had the 2009 pandemic. And if we look at both of those pandemics, vaccinated healthcare workers had less absenteeism, meaning there were more people to work in the healthcare setting, and they had higher rates of acceptance of pandemic vaccine and the COVID-19 vaccine. And a lot of the data that Rena has just presented has indicated that we had more people getting vaccinated, we had better acceptance of people getting vaccinated, and we had better advocacy for COVID-19 vaccination from the healthcare workers. So the introduction of seasonal influenza vaccination also strengthens and streamlines the regulatory systems for pandemic vaccine introduction. It also strengthens the regulatory preparedness for the provision of marketing authorization of emergency products. So in an essence, if you have a seasonal influenza vaccine program, the introduction of a pandemic influenza vaccine is not a huge leap. It is the same virus, and it's so a lot of the regulatory systems that are already in place can be used, and even some of the marketing authorization can probably be used. But for changing from seasonal to pandemic influenza vaccination is a small step compared to changing from, say, seasonal influenza vaccination to COVID vaccination or EBD vaccination, which is a totally different virus. So this does help in seasonal influenza vaccination, helps in pandemic preparedness, meaning that it maintains a ready platform for rapid introduction of the pandemic vaccine. So if we think about the seasonal influenza vaccine landscape in the African region and where it stands today, and this is data from the JRF, which is the a survey that is put around about vaccination policies and vaccination availability in countries, we can see that a number of countries, 19%, have a policy for seasonal influenza vaccination and generally have vaccine available in their populations. 32% have seasonal influenza vaccine licensed by their national regulatory authority, and some have the vaccine available, and that may be in the private or the public sector, and 30% have availability of the vaccine. So quite often a vaccine may be available in the private sector, but not necessarily in the public sector. So, and this only represents 18 out of the 47 countries in the region. So coming back to our question, why would we want to vaccinate healthcare workers? One, I think we've shown that it protects a vital workforce and is cost effective. We have less absenteeism. We're not putting stress on our healthcare system. It reduces the delivery time for influenza and other vaccines in the event of a pandemic. It means we have all the regulatory processes in place for the delivery of the vaccine. Vaccinated healthcare workers can act as advocates for vaccine uptake. So we've seen that there was, where you did have seasonal influenza programs, you got better coverage for the COVID vaccine, and that leads into the improvement of acceptability of adult vaccination in a post-COVID landscape. So looking at the life course approach. And then finally, this is a critical element of pandemic preparedness. So I think that is our last slide. We have a moment for questions, but what I think we might do is maybe hand over to Joe and then have questions at the end. So I will stop sharing now. I think I'm frozen. I think, Joe, if you share your slides and then we will go through your brief presentation and then we will have questions at the end. So over to you, Joe.
Great, and thank you very much, Belinda. Happy to be on the call, and thanks so much for the kind invitation to join everyone. I'll be very brief. We have a program at the Task Force for Global Health that is a collaboration with the Centers for Disease Control in Atlanta that was started really after the 2009 H1N1 pandemic, or shortly after that, really recognizing just what Rena and Belinda said about the value of influenza vaccinations in allowing countries to respond to that pandemic. So we began to work with countries to facilitate or support their objectives around influenza vaccination, and have continued that program now, and I'll talk about what that program is, but recognizing again the value of life course vaccination for pandemic preparedness, and influenza being a representative antigen for life course vaccination. PIVI, which is called the Partnership for International Vaccine Initiatives, used to be called Influenza Vaccine Introduction, but we recognize that in fact influenza is just one of many antigens in the life course that can probably provide a pandemic boost. So we've changed the name to indicate that we support broad life course vaccination at this point. But PIVI was started in 2013, and it's really meant to do three things. The first is to create sustainable respiratory vaccination programs in low and middle income countries. The second is to build the immunization infrastructure for responding to pandemics and other epidemics for which vaccines are useful. And the third is to share or generate knowledge from country work that supports countries or global stakeholders' decisions on investments in these vaccine programs. PIVI is a partnership. It's a partnership between three groups: country partners, which are the ministries of health, which do the heavy lifting and deliver the vaccine programs. We have contributing partners that give funding, vaccine supplies, shipping sometimes, and we have technical collaborators that provide technical support as needed to country partners that are interested in certain particular activities, which I'll go into in a second. It's all coordinated by the task force and CDC, as indicated there. The principles of our partnership are these. First, that PIVI works completely in support and in alignment with the Ministry of Health goals for influenza vaccination or other vaccines. We don't come to the partnership or come to discussions with countries with our own goals. We listen and try to support what we can to support a country's objectives in expanding or initiating influenza vaccination programs. We also work in support of the WHO regional offices and WHO headquarters objectives and visions. All our work in every country is done in alignment with, in coordination and collaboration with WHO. And finally, we work in support of CDC's global influenza vaccine program, who's our major funder. Second principle is that it's a true partnership. It really is a partnership between the Ministries of Health, the vaccine providers, CDC, our group at the task force, WHO, and others. Everybody has an active voice in the partnership and what happens with the work. We're committed to collaborating with each partner for multiple years is one of our principles. We realize that building vaccine programs for health workers, for instance, is not a one-year enterprise. It's a multi-year enterprise. So when we engage countries in the partnership, we engage for multiple years, recognizing that everything takes time. And finally, we work in not only support of reduction of annual disease, but also, as Belinda said eloquently, to build systems for epidemic and pandemic vaccine responses. We have two models of how we support countries. The first is in countries with existing influenza vaccine programs at a national level, at a public level, we can support with technical assistance and some modest funding for a variety of things, which I'll talk about in the next slide. In countries with no influenza vaccination program in the public sector, or countries wishing to expand to a new risk group, we can support technical assistance and funding as before, but also with provision of vaccine doses to initiate that country work. The vaccine doses are modest in number and are perfect for something like health worker vaccinations, which tend to be a smaller target group. They're always WHO pre-qualified. They're generally bought through UNICEF tenders, and we buy them for a period of time, sort of a several-year period of time, at which time the governments that we work with can take a decision to continue the program or not, based on the experience they've gained during that time. The approach is, again, a multi-year approach. We work with countries to define their goals and their activities over multiple years. And early on, we provided more vaccines with fewer vaccines provided later on. And these bulleted items are sort of a smorgasbord or a menu of the type of technical assistance that we can provide as countries need it. Anything from planning to implementation to evaluation of the programs. And again, we do that not only in collaboration with WHO, but we do that generally using WHO-developed tools. You see the box at the bottom. Those kind of tools are our sort of what we generally work through. So it's not only in collaboration with WHO, but actually taking advantage of WHO's thoughtful development of tools for these sorts of technical support activities. This is where we are and where we've been. We started in 2012-13 with a couple of countries as an opportunistic program. We built over time by countries that are interested in expanding or starting an influenza vaccination program. On the right side, you see that growth over time. We're in 26 countries now. You see that the dark blue countries are countries that got vaccine donations. The light blue countries are countries that only got technical assistance. And you see that some of the dark blue countries turn light blue on the right side as we go along, as they incorporate influenza vaccination into their national budget, national EPI programs. So we continue to provide technical assistance even to those countries once they develop their own program. The map on the left is where we are, and you see a list of countries. You see notably that there are two sub-Saharan Africa countries in the Afro region, Kenya and Cote d'Ivoire, only at this point. The country activities when we engage countries are these. First, we work with the countries, the ministries of health, to develop a multi-year strategic plan that outlines the target groups, outlines the coverage goals in that target groups, outline the types of vaccines that the country wishes to procure. And then we proceed to try to match technical assistance funding and vaccine doses to adhere to that strategic plan, knowing that the strategic plan can change every year, which it often does, but we like to start with a long-term view. Each country then develops an annual work plan that involves the funding they need, the vaccines they need, the technical assistance they need for that year, and we try to match, again, our resources to that request. Each country reports on what they did with the vaccine or what they did with the funding each year in a small one-page form. And then as part of the partnership, countries attend international meetings, are invited to support peer-reviewed manuscripts, webinars, et cetera, as part of the knowledge sharing, knowledge generation part of the program. Our priorities for the next couple of years are to grow, to support more and more countries as countries emerge from the pandemic and are interested more in life course vaccination, health worker vaccination. We want to make sure that we can support as much as we can those countries to do that. Expand to new countries is one of our goals, and really that means regionally. We found more efficiency in supporting several countries in a region than countries that are sporadic and kind of moved all over the world. And so looking for efficient regional collaborations like these. We'll continue to create knowledge. As we get more countries, there's more knowledge available. And so more papers, more webinars, more sharing experiences between the countries. And finally, that last bullet can't be overstated. And that is we want to make sure that the work we do is completely aligned, again, with global partners, that we have a complementary role in the global landscape around life course vaccination and influenza, and that we contribute to everyone else's goals in that respect. And I'll stop there and happy to turn it back to you, Belinda.
Thank you very much, Joe, for the very informative presentation. And just to let everybody know, we are working in partnership with Joe and his group. So we're looking forward to working with some countries and expanding some of these initiatives in the region. So I think at the moment I will open it up for questions. I'm not sure if I can see hands, but please feel free to put your questions in the Q&A, which is a function on the bottom bar of the screen. And I'm going to switch my view to see if I can see hands. Or Mohammed, can you help with seeing hands?
There is no hands for the moment.
No hands for the moment, which is terrific. We've explained everything so well, so, which is really good. Any other comments from you, Rena, or Joe?
Rita?
No, nothing from me.
Nothing from you?
No, Belinda.
Oh, we do have
there's
one
a hand.
hand. Professor Becky Tagbo, over to you. I think I will. Good morning.
They cannot do all of them.
Okay, so it's
Even look at the presentation.
Hello.
The
Hello.
presentations that you sent to me. That you copied me on.
yeah.
Look at those presentations. They cannot do all of that.
Can you hear me? Hello.
Yes. Is that Professor Becky?
Yes.
Okay,
Okay, so
somebody else has their microphone open,
But
or
it's,
you have somebody speaking behind you.
Okay.
I can send one of the webinars to you, for example, the first one.
Mohammed, can you mute yourself?
Wait.
Mohammed, can you mute yourself,
Yes.
please?
Okay.
Can you mute yourself, please? Okay, over to you, Professor Becky.
Thank you very much. Thank you for
That's
the
much better.
Thank you for the presentation. I saw one of the slides talking about influenza vaccines, availability of the vaccines, and I saw that I'm from Nigeria, and I know that the vaccines are available in the private market, but I don't think it's reflected on that slide.
That's okay. We will correct that. So this is information that is gathered through a survey that is potentially sent to, I guess, the Ministry of Health. So that is one thing, that Nigeria does have a policy, but it didn't have a box for vaccine availability. So we will correct that. But that is really good to know that it's available in the private sector in conjunction with the policy that they have in the country. Thank you.
Yeah, thank you. It's actually even institutions are making their own policies to vaccinate their health workers. It's just that it's not yet a total federal government program, but it's there. Some states also have their policies, so we are driving to expand it. Thank you.
Okay, could I ask you a question? So is the policy decision making based on the private sector or private health health facilities, or is it state by state ministries of health that would make the decision in Nigeria? Because I know it's a very big country.
Yeah, it's a very big country, and we have if the vaccine is in the national program, then it has to be made by the federal government. But like the influenza, which is not yet in the national immunization program, is just in the private market. But then the federal government has, the regulatory agency has allowed it. So in terms of regulation, there is regulation. Otherwise, it will not be used by the private people. So the pharmaceuticals have it approved and they bring it into the country, and people can access it privately. But we also have it in some institutions, like some teaching hospitals. They've made their own institutional policies and they are using the vaccine. So what is left is to get it into the federal government national program. Thank you.
Okay, so you would need some support with policy development from
Yes.
at the national level.
Advocacy, especially
Okay.
advocacy. Yeah.
Super, thank you. Hopefully this has helped with some of the advocacy material that you may need. Are there any other questions from other countries? Thank you very much, Professor Becky.
Thank you.
There are 2 questions, or maybe even 3 in the Q&A now.
Okay.
One I think would be good to talk about, which I think Joe had briefly mentioned, the vaccine availability.
Okay. So the question is, apart from good presentation, so claps to everyone, the vaccine availability is a bit expensive for countries, and then availability of the vaccine when needed. What can be done with this?
Yeah, I'm happy to take that if that's okay.
Yeah.
Yeah, it's a really good question. The vaccine the influenza vaccines are relatively expensive compared to EPI vaccines. That's certainly true. The UNICEF purchases vaccines on behalf of countries, especially countries that buy other vaccines through UNICEF and get a preferential price. That price changes each year and by presentation, et cetera. But you might reach out to your country UNICEF contacts to get those annual prices. We buy all our vaccines through UNICEF for our program using an MOU we have on behalf of countries. And so that's another avenue to get those UNICEF prices. But again, if you're thinking about a vaccine compared to measles or DTP, OPV vaccines, IPV, influenza vaccines are relatively expensive. The good thing is that as Belinda showed, that in countries, even middle income countries or low income countries, influenza vaccine is often cost effective or even cost savings in some groups like health workers. And so expensive, yes, relatively speaking. Health workers, we think, are a good target for countries thinking about influenza vaccination is either in a disease reduction or a pandemic preparedness, because the group of health workers in a countries is the smallest of the SAGE recommended groups, and so is it takes a relatively modest investment compared to some of the other groups to start with.
Thanks, Joe. And I think that sort of stresses the point that, during the pandemic, it's like we saw that the healthcare workers were, affected. And considering a lot of the situations in the region is that the healthcare workers may not necessarily get infected at work, but they may get infected, potentially infected in their home environment. So protecting them as part of their workplace, functioning, may protect them from getting infected outside of the work environment. So another question is, what is being done to encourage the rest of African countries to have the policies in place and the influenza immunization integrated into their national program? Well, this webinar is part of that. We are trying to encourage countries to look at putting influenza vaccination as a priority for high-risk groups, particularly, as Joe mentioned, the healthcare worker group, because it is one of the smallest populations for the SAGE recommendations. A couple of years ago, we did have some input into the RITAG meeting to, I guess, open the discussion about having influenza vaccination in risk groups. And then also, as Joe mentioned, there is some technical assistance for the introduction, or to speak to, or to generate discussions to NITAGs in countries to have influenza vaccination. One avenue is to look at pandemic preparedness, and the other avenue is to look at the burden of the disease in your country that influenza poses. And that's not just with mortality, but also with morbidity and absenteeism. So countries are developing their influenza surveillance programs, and some countries have more advanced programs than others. But, with a couple of years of data, you can determine what your burden of disease is. And that may be a way to advocate for influenza vaccination in high-risk groups or across the population. But this initiative is looking at healthcare workers as a starting point for, this advocacy towards seasonal influenza vaccination. So anything to add to that, Joe?
No, thanks.
No, all good.
It looks like
there's a question about secondary effects, or is that side effects of vaccinations with people with comorbidities? So, Rena, do you want to as a non-medical professional, I can't answer that question. But if we can't answer it here, we will find out the information and share it with you. And just to also, I guess, say that, we are doing this in collaboration with our VPD colleagues, our vaccination colleagues here at AFRO, and partners on the ground. So are there there's no other questions in the Q&A and no other hands. I can't see any hands.
Well, Belinda, if it's okay, the question that was asked about the secondary effects of vaccination on comorbidities, if I take it to mean asking about the potential value of the vaccine on reducing effects among people with comorbidities, I think that one of the things we might say is that part of the disease burden that Belinda just mentioned associated with influenza is direct respiratory disease that causes deaths, hospitalizations, clinic visits, et cetera. But another big part of the disease burden are non-respiratory disease, and these are largely effects of making people with comorbidities have complications of their comorbidities, diabetics who are hospitalized for diabetic problems, or people with heart disease, diabetic with congestive heart failure, for instance, that get influenza and get worsening of their cardiac disease and are hospitalized for that. that fraction of the disease burden is being studied very closely right now by groups that are led by the WHO Global Influenza Programs Disease Burden Working Group. I think there'll be more data on those groups, but clearly, I think some of the data that are known now are there's a large disease burden associated with people with chronic diseases that would not be picked up because they're positive for influenza when they're hospitalized, but are hospitalized because they got influenza and had worsening of their care. And second is that vaccines can protect or prevent those outcomes to some extent, at least. And the magnitude of each of those effects, both the disease burden and the vaccine preventable burden, are an active area of study. But I think soon that those data can be incorporated into your national activities to weigh the benefits, the cost benefits of an influenza vaccination program. So stay tuned. I think in the next year, there'll be much more data on those things.
Thanks, Joe. And I see that there's a Linus, you have your hand up. So welcome, Linus. And I'm not sure if I unmute you. I think you're unmuted. So over to you. Yes, you're unmuted.
Good.
So please go ahead.
You can hear me. Thanks. This is good and wonderful presentation and discussion. My question was really following up the other one, that the availability of this influenza vaccine, especially the northern or southern hemisphere within this region, it can be challenging. What can we do? Because sometimes when you need, in terms of its shelf life, especially now for the northern hemisphere, it's not available now. We are waiting for the southern hemisphere, and countries that really have this flu all year round would like to have this available to them, that they can be able to vaccinate. Right now, for example, like Kenya, we just waiting for we started the northern hemisphere vaccination that got finished. So now we're waiting, and there are many of the workers who are waiting to be vaccinated. But now we are waiting for the northern hemisphere availability for southern, I mean, for it to be available, especially in countries, so that it can be delivered. So that's the challenge that I was asking. How can we, try to support or help in that? Thanks, and over.
Thanks, Linus. And I think, excuse me, as you know, that there's two vaccine composition meetings each year that work on very tight timelines for manufacturers. So I think once they have decided on the Northern Hemisphere, say, vaccine composition, it then goes to the manufacturers. So it is all based on the timelines from the vaccine composition meeting to the availability from the vaccine manufacturers. So there is assessment of the circulating viruses each year and each season, so that they can be adjusted to be better protective for the next season. So I don't know the exact time when manufacturers will have the Northern Hemisphere vaccine available, but I think, with each of the different hemisphere vaccines, it's just that waiting game for a little bit to make them available and to be ready for release. Any comments from you, Joe?
I'll just add that to Linus, that as you likely know, there's a paper that came out about a month ago from Kenyan data looking at the relative cost of implementing a year-round vaccination campaign in Kenya, which of course has year-round disease, versus an annual vaccination campaign. They're really nice data and probably relevant to a lot of countries that have year-round vaccine. We can share that paper for your view after the call.
Thanks very much, Joe. So I think I'll close that question for the moment. And Rena, you wanted to answer the question that is in the chat. So the question in the chat is vaccination resistance is high among healthcare workers. Whoops, no, it's gone. What are the policies put in place to help reduce this. And I think this might be, something that a lot of people think of with respect to vaccine hesitancy, vaccine resistance, not just among the general population, but the healthcare worker population. So over to you, Rena.
Yeah, that's a tricky one because we've seen a lot of vaccine hesitancy, reduced confidence. And there's been a lot of work that's been done to try to figure out what are the factors. I think in this case, policies in place, maybe not so much policies at this stage, but more focus on really educating healthcare workers about the value of seasonal influenza vaccination, the benefits, really focused on the community, and how we can improve uptake. I think that there's been some other different things that have been studied, including incentives, non-monetary incentives. And, I think it would just be very dependent on the country context, and what needs to be done and what are those factors that are affecting the healthcare worker confidence in the vaccine. I don't know if anyone, Belinda or Joe, wants to add anything more to that. I think it's a tricky subject that we need to think a lot about as we roll this out.
Yeah, and I think that, preparing advocacy material for the healthcare worker population and also in specific country context would, is something that we could and we should work at WHO with our risk communication colleagues. I see that there was a question in Portuguese in the chat, and it looks like you asked, did we answer that question? Faustina Paxi, if you would like to ask your question so that we can hear it, then with the interpreters, then we'll be able to answer it for you. If you put your hand up. Faustino Paxi? Can I unmute you so you can ask your question? Okay. With that, we'll take the question on board and we will answer it in excuse me. We'll send an answer to you. Okay, so Misa has a hand up. I will unmute you, I think. No, I don't know.
Oui, bonjour.
Oui, bonjour. Okay, please go ahead.
Je voudrais, en fait, ma question porte sur l'intégration de la PCI dans la vaccination. Et on sait qu'aujourd'hui, il y a des structures santé qui font des stratégies avancées. Et par rapport à cela, je voudrais vraiment être clarifié un peu sur les dispositions pratiques concernant la PCI dans la vaccination. Merci.
I'm not clear about what BCI is. Joe or Rena?
La PCI, c'est la prévention et le contrôle de l'infection.
Oh. So
it's
infection
IPC.
prevention and colds,
Mhm.
IPC. So I'm sorry, what is the question? What is the role
Oui,
of
PCI en
IPC?
anglais, c'est IPC. Oui, c'est IPC.
Oui, say IPC. What is the role of IPC in vaccination
Donc,
programs?
ma question portait sur l'intégration de la PCI dans la vaccination, parce qu'on sait que la vaccination, des fois, produit des déchets, et souvent, par rapport à la gestion même des déchets biomédicaux, maintenant, souvent, peut-être comme on le dit, souvent, il y a des déficits de boîtes de sécurité, etc. Et dans les pratiques, on voit que souvent, il y a des méthodes qui ne sont pas tellement adaptées à ça. Et bon, c'est pourquoi je voudrais à ce niveau qu'on y revienne un peu sur les deux à la fois, c'est-à-dire en fait l'intégration de la PCI dans la vaccination. Merci.
So I think that's a good point, and I've just been to a national vaccine deployment plan workshop, and so that comes around the idea of the actual deployment of the vaccine into the community or places like that. So, waste management is an important concept in anything, even from a laboratory perspective. So there are components of vaccination that do deal with waste management and infection prevention and control of the people who deliver the vaccine. That is not really the scope of this webinar at the moment, but if you need some information on that, I can certainly share with you the components that are required for waste management, and also put you in contact with IPC colleagues here at the regional office to answer those questions. I'm not sure if Rena or Joe, you have anything to add to that.
I'd only say it's a great question, and I'd only say that as you indicate, vaccination is one component of prevention and control strategies for influenza. IPC is another important component, and we realized how effective it can be during the pandemic. So we would suggest that influenza vaccination programs for health workers exist in the context of a strong IPC program as well, of course.
Yeah, so public health and social measures in regard to IPC for control of influenza are critically important. So vaccination doesn't, as Joe said, doesn't act as a single silo. It's part of a comprehensive package of, pandemic prevention modalities. I can't see, are there any, there's one new question in French. So Rena, did you want to look at that? And I don't see any hands.
So I think, Belinda, this question is probably for you, because they're asking about a map of the epidemiology of flu in the region, just to determine the potential, the risk potential, and whether, vaccination makes sense.
Okay, so that's a good question. So we try to encourage countries to do surveillance for influenza year round. And, we know in this region that in the southern countries, so probably from Mozambique, Zambia, Namibia, Botswana, South Africa, Eswatini, and Lesotho, they have, in Zimbabwe, they have a defined season that correlates with the Southern Hemisphere season. The northern country, Algeria, also has a seasonality that equates with the European or Northern Hemisphere season. The rest of the countries in Africa appear to have, or seem to have, influenza activity year round. And so, as Linus was mentioning from Kenya, they have year-round activity. And so deciding what vaccine to use, whether it's the Northern Hemisphere or the Southern Hemisphere, then has an issue. So, we're trying to get everybody on board with looking at influenza data to determine the seasonality and the burden of disease. And if you're interested in looking at or finding out for your particular country, I'm not sure which country it is, what the seasonality or when the infections occur in your country, or if it has, a particular time, I would direct you towards FluNet, which is a global influenza platform from WHO. And if you type into Google FluNet, it will come up, where you can select your country or neighboring countries to see when their influenza activity is during the year, which may then guide when you may want to start campaigning for influenza vaccination, or may help you decide on which influenza vaccine to use. So if you want any more details, please don't hesitate to contact me. And I think I will put my email in the chat so that people can have it. And there was also a comment in the chat from Liberia, I think. In my home country, Liberia, vaccination with influenza vaccine is since 2009. What for healthcare workers, what are we doing more to have this vaccine for healthcare workers on a regular basis? So that's once again what this webinar is all about. It's about sort of looking at advocating for healthcare worker vaccination, looking at moving or discussing or opening discussions with NITAGs to get the vaccine licensed in your country if it's not licensed in your country. And then if the vaccine is licensed in your country, helping countries move towards having a policy for healthcare workers, which is one of the high risk groups, vaccinated. So we're almost at time, and there's one more question in the Q&A. Can you share any experience encountered in vaccination hesitancy among healthcare workers? And that would be helpful to hear the necessary measures taken facing that. I think there are probably plenty of examples during the COVID pandemic about vaccination hesitancy. I'm going to pass it over to Rena, our expert, who's been working with COVID and also particularly not just COVID vaccine, but other vaccines for healthcare workers and the hesitancy and reactions. Over to you, Rena.
Sure, I'll try to be really brief because I know we're a minute over.
Yeah.
Yeah, so as I mentioned previously, you know, a lot of work has been done in terms of actual training and just really explaining to healthcare workers in depth the utility of the vaccine, whether it's influenza or another antigen, and how it can be beneficial. Also giving them materials on vaccine efficacy and safety profile, and just really giving them the materials so they feel that they're educated and understand the details of the vaccine. A lot of work has been done surrounding that, and I'm happy to share materials as we send out, because this question has come up multiple times, about some of the factors associated with vaccine uptake among healthcare workers and some of the interventions that other countries have tried to increase vaccine uptake. So I'll include that in the materials.
Okay, thank you very much, Rena. Since we're now 2 minutes over, I will draw the webinar to a close. So once again, thank you very much, Joe, for your input. Outstanding and very helpful, and we look forward to working with you further in the next coming months. Thank you to my colleague Rena in DRC, and thank you to all the participants and your input for this webinar. We look forward to hearing from you if you think this is something that you may want to pursue in your country. And once again, thank you and have a lovely week. Bye for now.
Everybody, thanks, Linda.
Thanks so much.